So radical cystectomy has always been part of our guidelines for non-muscle invasive bladder cancer. And in a bygone era that wasn't too long ago, once cancers were resistant or failed BCG, there weren't a lot of great salvage options. And so radical cystectomy has always been a part of our guidelines in that space. We now are in an era where there are multiple options that patients can consider. But one of the things that we all confront as treating providers is, we don't want a patient to lose sort of this window of curability in their care. So I think we as urologists and surgeons always have in the back of our mind, how strongly should I be advocating for radical cystectomy for this patient? But we also confront with that really strong patient preferences, because patients pretty universally want something that will help them keep their bladder. In that comparison, though, radical cystectomy versus the sort of now panoply of available options for intravesical therapy or intravenous therapy that we call bladder-sparing therapies, there's not tremendous evidence to make that comparison. And so that's why we came up with the CISTO study. So our study was in a non-muscle invasive bladder cancer population. And in that population, when we think about bladder-sparing therapy, we're thinking about treatment into the bladder, like intravesical therapy. Now, because of regulatory changes, since we started the study, there's also intravenous immunotherapy that's an option for non-muscle invasive bladder cancer. So I am a co-PI with Angela Smith at UNC of the CISTO study, which is a comparison of surgery and intravesical therapy as treatment options for recurrent high-grade non-muscle invasive bladder cancer. This was a study that was born about directly from patient input. So we had worked with the Bladder Cancer Advocacy Network to create something called the Beacon Patient Survey Network. And our main use of this was research prioritization. What are the questions that patients can help us with, because we don't have that lived experience of the bladder cancer patient? And the top questions were the same things that we struggle with. How do you make a decision about bladder removal with cystectomy? And what do you do when the cancer comes back and BCG doesn't work? And so the CISTO study compares those two groups. Whenever you're comparing a big surgery with a more conservative strategy, patient preferences can really affect your ability to do a randomized controlled trial. And patients told us it just wasn't a feasible thing to do. So it is an observational study. And when that happens, you can get an imbalance in the two patient groups by certain characteristics. So our cystectomy patients tended to be younger. They tended to have worse cancers, because obviously you're going to drive those patients more toward a more definitive treatment. But what we can use is we can apply these methods, because we've collected a lot of data on these patients, to sort of counterbalance the selection bias. And so the trick we used was something called targeted maximum likelihood estimation. And it's a statistical technique to essentially coax randomization out of this observational data. Our main outcome for the CISTO study, for this initial 12-month review, was physical functioning. So that's a quality of life outcome, not what we typically think of as a clinical outcome. But we had thought, because radical cystectomy is such a big surgery, we had thought that the cystectomy patients would have worse general quality of life and physical functioning 12 months after we recruited them into the study. And what we found was it was no different. So the cystectomy patients had just as good physical functioning and quality of life as the bladder-sparing therapy patients. So when that patient tells you, gosh, I'm worried that this is drastically going to change my current health and my current ability to do the things I like to do, our results help you say, actually that's not true. Yes, it's a big surgery with a big recovery, but once you're 6 months, 9 months out, you're going to be similar to your baseline and the same as those patients who still have their bladders. What you're also talking about are sort of subgroups. Are there different populations that had more benefit? We did find more benefit toward radical cystectomy for patients who had concomitant carcinoma in situ, and that's in their bladder. It's probably because those patients also had probably an increase in urinary and irritative symptoms, bothersome symptoms in their urinary tract, and that also tends to be a fairly recalcitrant feature of these cancers that can make intravesical therapy harder or less effective. And then we also found, surprising to us, that our rural individuals, people who didn't live in urban areas, had differential benefit from radical cystectomy, did better with radical cystectomy. And that may relate to just this overarching challenge when you live far away from, say, a cancer center like ours, with intravesical therapy of getting to the cancer center for repeated treatments, repeated surveillance evaluations. It's a lot. And so that may have been more of an onus on our rural patients, hence why they did better with sort of a one-off treatment. So I think one of the things we are trying to work on is, pursuant to your question about who benefits and who doesn't, with any comparison, any trial, you come away with this average effect of the treatment. A is better than B by 5%. But there's a lot of heterogeneity in that benefit. And so there are people that definitely benefited more than that, and there are people that maybe were harmed by the treatment we thought was better. And so we're trying to figure out how that shakes out. For patients with this profile and these preferences, how did the comparison work for them? And in that way, we hope to be able to take the CISTO data and help clinicians and patients make better decisions for themselves. The other big thing on the horizon for us is, in addition to the funding that supported the initial CISTO study, we have additional funding from the National Cancer Institute to get longer-term outcomes. So what I presented today were 12-month outcomes, but we'll be able to have 24-month and 60-month, 5-year outcomes, which will really help us with kind of understanding the long-term implications of this decision to keep your bladder or not. Part of our multi-stakeholder engagement as part of the CISTO study was making sure that we had a representative of bladder cancer guidelines as part of our executive committee. So Sam Ching, who's on our executive committee, serves on the guidelines panel for bladder cancer. And so our hope is to take this data and help it inform those statements that appear in our guidelines, which tend to be more expert opinion based. And now, ours is the only study that's providing evidence for or against cystectomy in that comparison. And so we hope that we're providing sort of some evidentiary standard that supports, radical cystectomy as a considered option for these patients.